Patient's had prior abdominal surgery in her umbilicus.
Hi, I'm Dr. Erik Dutson. I'm the Chief of Minimally Invasive and Bariatric Surgery here at UCLA, and I'm the Executive Director of CASIT, which is a Center for Advanced Surgical and Interventional Technology. The case we did today was a 21-year-old female who had something known as median arcuate ligament syndrome. Basically, she presented with abdominal pain of unknown etiology and underwent a very exhaustive workup and presented to us with findings, radiographic findings on her CAT scan that demonstrated what's called notching on the celiac artery.
So we use a first entry trocar that has a hole in the tip so that as we go in optically, the hole does low-level insufflation. That way we don't have to put the entire optical trocar in the abdomen before we start insufflating. This sort of supplants the need for a varus needle or pre-insufflation. When we look around the rest of the abdomen, nothing exciting, pretty normal anatomy except for some adhesions here from her prior cholecystectomy to the greater omentum in the back of the umbilicus. We're going to be all up in the upper abdomen, and we're going to have to get the liver out of the way to do the operation.
These cases were traditionally done via an open approach with a wide dissection and proximal and distal control of the aorta and a thorough ganglionectomy as part of the standard approach to it. With the advent of minimally invasive surgery, surgeons began to do the operation laparoscopically with a much reduced recovery time for the patients, with much less pain and with success. Recently, we've started doing this operation using the Da Vinci system because the articulations at the wrist give us a mechanically superior approach to this very challenging part of the abdomen. So when I do these operations, I always use the robotic system because it allows me to do a much more thorough and precise dissection in this very anatomically challenging location.
All right, we're going to start off here. The patient actually has anatomy that should help us get to where we're going. This is the pancreas here. Here's the stomach coming around, lesser curvature. We've got some lymphadenopathy, presumably along the celiac branches, which by itself is abnormal. We wouldn't expect to see inflammation in this area under normal circumstances. And for that reason, it's supportive of the idea that she has a problem at her celiac axis. If you look when we do that, I think the thumping there with muscle over top of it is the aorta itself. Do you agree? This shape, this curvilinear shape like that is a tube, which corresponds to the aorta in my opinion. And the reason I think that is because when we go out left lateral like this, we don't really see any further muscle. If that wasn't the aorta, then we would see more muscle here going up to the left cruce. Now, if we look with the camera just for a second, left cruce is here, right? This is the GE junction. You can see the anchoring of left cruce up by the central tendon. Right cruce is over here. And when we look down right here, it's pretty easy in your mind's eye to project that going straight up to the left cruce, meaning that we're at the area where they cross. So the case is over now. We divide the ligament fully with the robot. We convert back to laparoscopy after we undock the robot to verify that we've removed our liver retractor without any problems, and also that each of the trocar sites, when we remove them, doesn't have any postoperative trocar site bleeding. Let all the gas out of the abdomen, and then we close the skin. Use some Marcaine for postoperative pain control.